So atherosclerosis is the cause of ischemic heart disease. What is it that causes the atherosclerosis? Well, in any particular individual, it might be difficult to say precisely what has caused their ischemic heart disease, but there are well-recognised risk factors. And sometimes we divide these into non-modifiable risk factors and modifiable risk factors. So first of all, let's think about the non-modifiable risk factors. And the first of these is age. So the longer someone lives, the more time they have to develop ischemic heart disease, the more time there is for the disease process to progress. So older people in their 60s and 70s are much more likely to get ischemic heart disease than younger people in their 20s, 30s or 40s. We can't modify it, but it is worth knowing about. Another non-modifiable risk factor is the person's sex. Younger women, premenopausal women, are protected by estrogen. So younger women get less ischemic heart disease than men of comparable ages. But after the menopause, when the amounts of estrogen go down, then women start catching up, until in older age groups it's roughly the same number of men and women suffer from ischemic heart disease. Now, given that it's estrogen that is protecting premenopausal women, for a long time it was thought that giving estrogen after the menopause as an HRT, as a hormonal replacement therapy, would be protective. We now know that this is not the case. Giving postmenopausal women estrogen does not protect them against the development of ischemic heart disease. Now, another non-modifiable risk factor is family history, race and genetics. Now, a family can share particular behavioural characteristics as well as genetics, but there are genetic predispositions to ischemic heart disease. And very often these genetic predispositions are acting on particular etiological factors such as dyslipidemia, hypertension, obesity, diabetes mellitus. But there is a tendency for ischemic heart disease to run in families. Of course, you can't change your race, but certain races do seem to have an increased predisposition, depending on the environment they live in. So, for example, people from the subcontinent and Asia who move to the UK have more ischemic heart disease than people that always lived in the UK because of the interaction of their genetics with the Western lifestyle that they often adopt. So it's very important, if people do have an increased genetic predisposition, which we can't alter, is to give them very good health education advice to modify the risk factors that we can affect, that we can reduce, that we can alter. Which brings us on to the modifiable risk factors. What are the modifiable risk factors? Now, what do you think is the main avoidable cause of atherosclerosis and ischemic heart disease? If you can just give people one piece of advice, what would that be? I think it would be don't smoke cigarettes. Smoking is the main modifiable risk factor. We know that smokers are more likely to develop atherosclerosis, and we know that they're more likely to develop thrombosis. And we also know that if someone stops smoking, their risk of having a heart attack reduces within a few days because of the effects on the blood of stopping smoking. And within a few years of stopping smoking, depending on how long they've smoked for, but someone who's been smoked even for quite a few years, after 10 years, their level of risk from coronary heart disease can be the same as someone who's never smoked. So tremendous advantage in not smoking. We can modify that. Let's get people stopping smoking, or preferably not starting in the first place. Another big risk factor is physical inactivity. Physical inactivity roughly doubles the probability of developing cardiovascular disease and having a coronary event. So we need to encourage people to be active. Now, if people are very active and they're running half marathons and cycling for 50 miles at weekends, they're going to get a huge amount of protection against ischemic heart disease. But of course, most of us don't have the time or the ability indeed to do that. So even relatively modest amounts of exercise have very protective effects. So if we can exercise for even just 20 minutes or half an hour most days, certainly for 5 days a week, but 20 minutes to half hour exercise, not even that strenuous exercise, just like brisk walking or cycling or swimming, even that half hour for 5 times a week will confer about 75% of the amount of protection enjoyed by the people who are out running marathons and riding the Tour de France or whatever it is. So very important to do whatever physical activity you can. You won't get 100% of the protection that the marathon runner will get, but you can easily get the first 75% of that protection. So we need to advise people to get out there, half an hour a day, moderate exercise, preferably 5 or 6 days a week, and that's protective. Diet is another obvious factor. We know that people that eat a lot of polysaturated fats have a greater risk, but people that eat polyunsaturated fats as part of, for example, the Mediterranean diet can be protected. Eating fruit and vegetables are protective. So diet is very important. We want a healthy diet. Alcohol. What do you think alcohol does? Is alcohol good or bad? Well, the answer is alcohol is both. Small amounts of alcohol, and I actually do mean quite small amounts of alcohol here, 2.5 units, maybe 3-4 times a week, is protective. Small amounts of alcohol are protective. Larger amounts of alcohol are damaging. They will increase blood pressure, increasing the risk of cardiovascular disease. Large amounts of alcohol can also increase the harmful cholesterols in the blood as well. But moderate amounts of alcohol drinking confer a small benefit. What we don't do is tell people to start drinking to get cardiovascular protective benefits. But if someone's drinking already, then it's okay for them to carry on drinking in moderate amounts. We don't tell people to start drinking because a certain proportion of people that start drinking, that acts as like a trigger dose, and they end up drinking far too much because some people are genetically predisposed or in some way predisposed towards alcoholism. And once they get the feel of the alcohol molecules in their brain, they just start drinking far too much. They're fairly well recognised factors that we've mentioned so far. I think I'll do a couple of newer factors here. Lack of vitamin D. There is increasing evidence that lack of vitamin D is a big risk factor in the etiology of cardiovascular disease. Where do we get vitamin D from? Well, we get very little from the diet. Nearly all the vitamin D we get comes from the sunshine, exposure to sunshine. The skin makes vitamin D when it's exposed to sunshine. It's a sunshine vitamin. And lately, of course, there's been a lot of publicity about malignant melanoma, which is true. If you get sunburn, you're more likely to get malignant melanoma. But if you don't get enough sun, you're more likely to get various things like immunocompromise, ischemic heart disease, colon cancer, multiple sclerosis, maybe even type 1 diabetes mellitus. So vitamin D is protective against a range of conditions, and the evidence that one of these conditions is cardiovascular disease is increasing. And this is particularly a problem if you live in northern latitudes where we don't get much sunshine. And what other group of people might find lack of vitamin D a particular problem? Can you think of who else this might be a big issue for? Well, the advantage of having white skin is that you make more vitamin D. When I go out in the sun, I get burnt really quickly, but I make vitamin D quickly. But if people have darker coloured skin, they're going to make proportionately less vitamin D for a particular amount of sunshine exposure. So the worst possible combination is being very dark coloured and living at northern latitudes. That means that you're almost certainly not getting enough vitamin D from the sunshine. And of course, we can take vitamin D as an oral supplement, not as a multivitamin, but just as isolated vitamin D levels. So if we're concerned about this, what we can do is take someone's blood, look at their vitamin D levels and titrate it up to normal levels, and that does almost certainly have a protective effect. And another strange cause is having a dirty mouth. There's quite a lot of epidemiological studies on this as well. Good oral hygiene seems to be associated with reduced rates of cardiovascular disease. So get some sun and do brush your teeth twice a day. Now, as well as these lifestyle factors we've mentioned, there's a lot of disease factors which predispose towards cardiovascular disease. So there are primary disease conditions which give rise to secondary cardiovascular disease. And the one at the top of my list here is diabetes mellitus. Both type 1 and type 2 diabetes mellitus accelerates the development of the atherosclerosis, depending on the level of control. So the diabetics in your care must have good levels of glycemic control, good overall lifestyle factors to reduce the probability of them developing cardiovascular disease, sometimes at a tragically early age. We can treat that, it's modifiable. Another one is dyslipidemia, people who have high low density cholesterol. And again, we can screen for this and we can treat it by giving statins. We can modify it. As long as we think about it, detect it, we can modify it pharmacologically. Another big risk factor is hypertension. And again, we are very good at treating hypertension. As long as we recognise it, we can treat it and we can get it down. But with diabetes, dyslipidemia and hypertension, if we don't screen for it, if we don't recognise it, then it's going to cause a lot of atherosclerosis and patients can actually present with myocardial infarctions. Whereas if we screen for it at an earlier stage, we can prevent the atherosclerosis developing, which is going to prevent the ischemic heart disease, and the patient won't get the myocardial infarction. Now, you could count obesity as a disease if you want to. You could count it as a lifestyle factor. It doesn't matter too much. But obese people are more prone to cardiovascular disease, particularly central obesity. Obesity in and around the abdomen. The fat is metabolically more active, predisposing to ischemic heart disease. So people that are described as pears, who might be a bit thin here but have fat bottoms and legs, they are less prone to ischemic heart disease than apples, people that are fat in the middle. So don't get a fat tummy. That's a very important piece of advice. People with metabolic syndrome are very much more predisposed towards cardiovascular disease. And metabolic syndrome really is an increase in sugar, dyslipidemia with obesity and possible hypertension. That's metabolic syndrome. Now, coagulation factors can come into play, not so much that coagulation factors make atherosclerosis more likely, but they make thrombus formation more likely. So if people have activated platelets or high levels of fibrinogen or some genetic predisposition to hypercoagulability, that can be a risk factor for thrombosis. Personality. Sometimes people say that personality is a factor. The evidence for it isn't very good, but what is sometimes said is type A personalities, that's the driven, hyperactive personality, are more prone to heart disease than the type B personality, which is the kind of more laid back, sort of let it happen, phlegmatic sort of personality type. And we can actually explain most of these risk factors, or some of these risk factors, in terms of serum levels of cholesterol. Now, there's two sorts of cholesterol I'm going to illustrate graphically in a minute, but let's notice for now that HDL, high density lipoproteins, are cardioprotective. So high levels of HDL are protective. It's cardioprotective. But LDL, low density lipoprotein type cholesterol, is atherogenic. It will cause atherosclerosis. So people often have low levels of HDL, which predisposes them towards atherosclerosis, and high levels of LDL, which also predisposes them. We say these people are dyslipidemic. So ideally, we want high levels of HDL and low levels of LDL. So remember, HDL helpful, LDL harmful in terms of the development of atherosclerosis. Now, having said that, we don't know what all the factors are. These factors that we've discussed probably account for more than 60% of the etiology of the disease, but there are unknown factors as well. So this is something we're still working on, but because we know about these factors, we need to put them into operation to reduce the amount of atheroma that we see, and therefore the amount of ischemic heart disease that our people suffer from. Now, the risk factors for coronary arterial atherosclerosis are not additive, they are synergistic. They operate together. So if someone has a cholesterol of 8.6 millimoles a litre, then we see here that they have a 4 times increased chance of developing ischemic heart disease and having a cardiovascular event. And if someone's hypertensive, if the systolic blood pressure is 195 millimeters of mercury or higher, we see that there's a 3 times or a times 3 increased chance they'll have a cardiovascular event. And in fact, hypertension here, this example is systolic blood pressure, but it's also true if someone has a high diastolic blood pressure. Both systolic and diastolic are risk factors. But if someone's hypertensive and hypercholesterolemic, we see that there's a times 11 chance that they'll develop cardiovascular disease. Now, if someone smokes, their chances are increased by 1.5. And if they're hypertensive and smoke, the two combine together to give a times 4.5 chance. In other words, a cardiovascular event, if someone has this risk factor and this risk factor, is 4.5 times more likely. The same with cholesterol and smoking. It's round about times 6. They're 6 times more likely to develop a cardiovascular event. And if someone has high cholesterol, hypertension, and they smoke, it goes up to about 16. Such a person is 16 times more likely to have a cardiovascular event. So risk factors operate together. If someone's got one risk factor, we should screen for other risk factors. If someone has any one risk factor, screen for others, because the risk factors are synergistic, greatly increasing the chances that someone will have a adverse cardiovascular event as a result of coronary arterial atherosclerosis. So cholesterol is actually a carrier molecule. It's a bit like a truck. It carries things around. And we know that there's 2 forms of cholesterol: LDL, low density lipoprotein cholesterol, and HDL, high density lipoprotein cholesterol. But they have opposite functions. So here we have the liver, and here we have the blood. Now, if this truck is HDL cholesterol, high density lipoprotein cholesterol, what it does is it's going to take cholesterol from the blood, it's going to carry that cholesterol to the liver, and it's going to drop it off in the liver for biochemical processing. So HDL is taking cholesterol from the blood to the liver, fatty material from the blood to the liver. Can you see this means there's now less fatty material left in the blood to be atherogenic and cause atherosclerosis? So HDL, high density lipoprotein, is helpful, it's protective, it's cardioprotective. Conversely, low density lipoprotein cholesterol, so this is a different molecule now, this is now low density lipoprotein cholesterol. This takes cholesterol from the liver and dumps it off in the blood. So the more trucks you've got carrying cholesterol from the liver to the blood, that is, the more LDL cholesterol you have, Can you see the blood's now getting full up of cholesterol and fatty material that can migrate into the walls of the artery and cause atherosclerosis? So HDL protective, LDL atherogenic, the two forms of cholesterol. So it's good to have high levels of HDL and low levels of LDL. If people are dyslipidemic, they'll have high levels of LDL but low levels of HDL, and that's atherogenic. So why is it that we have LDL cholesterol then if it's just there to cause ischemic heart disease and atherosclerosis? Well, the answer is that in survival situations, we need to mobilise fat from the liver, because if you haven't eaten for a couple of days, you haven't got any glycogen and sugar left, very little sugar left, you're going to have to run on fat. And then we're going to have to take fatty material from the liver, take it to the blood, where it can be used for energy. And that's very protective. It's going to increase the probability of our survival in periods of fasting when there's no food available. The problem is in our society, food is always available, so we don't fast anything like as much as we should. So the way we look at it, HDL is good, LDL is bad. If you're in a survival situation, of course, you need the LDL. It becomes good to aid our chances of survival. But because we've got lots of food and plenty to eat all the time, what we need to try and do in our patients is get HDL levels up and LDL levels down.